Hello and welcome everyone. Today we'll be discussing an important topic, that is hydrocephalus and its management in the ICU. It is derived from the Greek word hydro, that is water, and head, cephalus. It is characterized by excessive accumulation of CSF in the brain. It is defined as an active distension of the ventricular system of the brain due to inadequate CSF passage from production to absorption. Standard treatment include the ventriculostomy and shunt implantation. Pre-implantation testing for CSF dynamics and patient's hydrodynamic compensatory reserve is crucial, and these are the aspects which we will be discussing in this particular video. Now, regarding the physiology, CSF dynamics are influenced by four components, that is the production, flow, absorption and pulsation, collectively called as the third circulation. Classic hypothesis of the CSF hydrodynamics is that CSF is produced from the choroid plexus around 500 ml. Remaining 30-40% of the CSF is produced from the interstitial fluid which exudes from the diaphragm. CSF circulates in the lateral ventricles and through the foramen of Monro. It goes to the third and fourth ventricles and then into the subarachnoid space. The path from the from the ventricles via the foramen of Magendie and foramen of Lusca, it enters the subarachnoid space. It then flows over the brain's cortical convexities to the skull base, where it is reabsorbed into the superior sagittal sinus through the arachnoid granulations. Now the dynamics. Pulsations observed in the cerebral aqueduct and the cervical subarachnoid space is influenced by an Windkissel effect, that is transferring of the energy from the arterial blood flow and the cardiac contractions to create what is called as the CSF pulsations. These pulsations have to maintain the pressure gradient throughout the CNS, aiding in the CSF drainage from cerebral ventricles. CSF production and absorption. Active CSF production occurs at the choroid plexus and it is absorbed in the venous sinuses by the arachnoid villi. So this diagram summarizes what we have discussed till now. It is produced in the choroid plexus. From there it enters the third and the fourth ventricle, and through the foramen of Lusca and Magendie it enters the subarachnoid space, and from there it also enters the cervical. These are the CSF oscillations and this is the pathway. Now there are four conditions where the patient can develop hydrocephalus. The first is post-SH. In this, the complication range from around 6 to 67% with an average of around 20 to 30%. It is divided into three phases: acute, subacute and chronic. The pathophysiology is that various causes have been implicated, including neuronal loss from secondary ischemic damage and obstruction to the CSF circulation. It significantly impairs the neurological function, potentially leading to severe disability, coma and death. The next is obstructive hydrocephalus, where you actually have a block in the circulation because of some kind of a space occupying lesion or inflammation. According to the classic Gandy experiment, which obstructions lead to ventricular dilatation because accumulation of the CSF at the blockage site. Now, ventricular system dilatation is driven by the transmantle pressure gradient, the difference between the interventricular pressure and the pressure inside the subarachnoid space of the cervical convexities. Historically, the choroid plexotomy was employed based on the belief that this could relieve the hydrocephalus. However, there is a challenge to the classical view because these type of operations did not actually result in benefit. So, stopping the production did not help in improving the hydrocephalus. Modern studies suggest that aqueductal narrowing or closure may result from progression of the hydrocephalic state. So, it is an effect rather than a cause for the hydrocephalus, indicating a secondary phenomenon of midbrain compression and axial herniation. So what do the recent experiments say? Studies by Clarica have indicated that during acute aqueductal blocks, CSF pressure in the ventricles remain unchanged and no dilatation occurs in the first few hours. These findings challenge the notion that aqueductal stenosis directly leads to the hydrocephalus. Next, what we have is called the communicating hydrocephalus. In this, there are no obstruction, but there is decreased absorption in the arachnoid granulations. This type of obstruction leads to dilatation of the ventricular system, while the aqueduct of Sylvius remains open and is sometimes expanded. Now, recent theories propose that alteration in the lymphatic pathway, specifically through the cribriform plate of the external lymphatic system in the nasal submucosa, play a role in this. And the process of how this obstruction leads to ventricular dilatation remains very complex, involving a transmantle pressure gradient which ideally should expand the subarachnoid space rather than the ventricles. The last and the most common cause is the post-craniectomy, because nowadays a lot of craniectomies are being done, especially in the ICU setup. So these are the patients which you will most commonly encounter, the post-traumatic brain injury and subarachnoid head hemorrhage patients who have undergone a decompressive craniectomy. And it is characterized by a syndrome that is called syndrome of refined, SOT, often presenting with unexplained neurological dysfunction. The incidence is around 25% for ischemic stroke, 15% for traumatic brain injury, and 20% for subarachnoid hemorrhage. Correlated with the severity of the initial traumatic brain injury and SS and the presence of a parafalcian subdural hygroma. The pathophysiology is that altered CNS dynamics due to the large cranial defect affects the brain expansion, CSF pulsatile flow, and the interstitial fluid clearance by the lymphatic system. Redistribution of the CSF to the subdural and the subglial components and the ventricle. Impact of the decompression. Now, the Monro-Kelly doctrine, it becomes invalid in the presence of a craniectomy, which impacts the normal brain and the CSF pulsations. As we saw that these are very important to expand and disseminate the pressure all throughout the brain, and it creates a large low pressure defect, dampening the pulsations and reducing the ventricle squeezing during cardiac pulsations, leading to a very flat ICP waveform. Now, the complications are external hydrocephalus can occur with clinical worsening, often not responding well to shunting. Now, delayed cranioplasty, that is beyond 3 to 6 months, increases the likelihood of the syndrome of refined head to occur and with hydrocephalus. So what are the new concepts and how will they help us in managing these type of patients? This is called the Marmarao CSF model. It basically deals with this kind of an electrical scenario. They are breaking down the CSF as into an electrical circuit. So the first we have the formation. This represents the CSF production in the corax plexus. Next we have the capacitor, that is the storage of the CSF or the compliance of the system. Next we have resistor. This represents a resistance to the CSF outflow. This is primarily encountered at the arachnoid granulations where the CSF is absorbed into the venous system. And finally, absorption. This component indicates the absorption of CSF into the bloodstream. So overall, all these things help in making us understand the concepts of how to use these new findings into our clinical practice and help these patients. So what are the clinical application of all this? The dynamic studies help us in differentiate between the type of hydrocephalus by measuring the CSF outflow, the resistance, and the compliance. We do infusion tests. There are two types of tests. The first is the bolus, where you assess the CSF outflow resistance by a rapid injection while monitoring the ICP. Then we have a continuous test where you slowly infuse and you check for the resistance by controlled fluid addition. Now, it helps us in guiding the treatment because it influences our decisions on intervention, like whether to go for a shunting or ventriculostomy based on the dynamic CSF measurements. Now, how is this being done? So, you assess the compliance and the pressure volume index. A high compliance and low pressure volume index suggests that there is brain atrophy, where the brain has higher capacity to accommodate a volume without significant pressure changes. However, if the compliance is low or the pressure volume index is high, it indicates that the brain compliance is typical in hydrocephalus, necessitating interventions like shunting. So, like in a post-craniectomy scenario where there is neuronal loss, so there is a chance of brain atrophy. So all the hydrocephalus that you see not necessarily will respond to the shunting. So this helps us in selecting those patients who will benefit from shunting. Finally, it helps us in the clinical decision making, where in cerebral atrophy, we do not need a shunt, and in hydrocephalus, which will be indicated by a high pressure volume index, we will need a shunt. And to monitor and follow post-intervention monitoring using the model to evaluate the effectiveness of the shunt and adapt treatments based on the patient's response. So that's it for today. Thank you for your patience.